Babies are born to be at ease. Nothing lets babies grow more at ease than their mother's love. But moms find it hard to follow their intuition when facing so many good intentions and advice. Nothing lets babies grow. We believe that nature has given moms the confidence to follow their own path. Moms find it hard to follow their intuition. That's why we support breastfeeding, the best nature has to offer. Nothing lets babies. And that's why we commit ourselves to creating the gentlest nutrition for the most precious little creatures in our lives. Kabrita is made with the natural gentleness of goat milk, and that's why it comes with the love of our farmers for their nutrition, for the centuries-old tradition of the Dutch for dairy, and the dedication of our experts for crafting the very best nutrition every day. Because we truly believe this gentle touch of nature makes all babies grow with ease and lets their moms sleep a little better too. The very best nutrition every day. Kabrita, because we gentle by nature. This gentle touch of nature makes all babies grow with ease.
عبد الرحمن في مشكلة في الفيديو ولا ايه؟
Babies are born to be at ease. Nothing lets babies grow more at ease than their mother's love. But moms find it hard to follow their intuition when facing so many good intentions and advice. We believe that nature has given moms the confidence to follow their own path. That's why we support breastfeeding, the best nature has to offer. And that's why we commit ourselves to creating the gentlest nutrition for the most precious little creatures in our lives. Kabrita is made with the natural gentleness of goat milk. It comes with the love of our farmers for their goats, the centuries-old tradition of the Dutch for dairy, and the dedication of our experts for crafting the very best nutrition every day. Because we truly believe this gentle touch of nature makes all babies grow with ease and lets their moms sleep a little better too. Kabrita, gentle by nature. Babies are born to be at ease. Nothing lets babies grow more at ease than their mother's love. But moms find it hard to follow their intuition when facing so many good intentions and advice. We believe that nature has given moms the confidence to follow their own path. That's why we support breastfeeding, the best nature has to offer. And that's why we commit ourselves to creating the gentlest nutrition for the most precious little creatures in our lives. Kabrita is made with the natural gentleness of goat milk. It comes with the love of our farmers for their goats, the centuries-old tradition of the Dutch for dairy, and the dedication of our experts for crafting the very best nutrition every day. Because we truly believe this gentle touch of nature makes all babies grow with ease and lets their moms sleep a little better too. Kabrita, gentle by nature. Babies are born to be at ease. Nothing lets babies grow more at ease than their mother's love. But moms find it hard to follow their intuition when facing so many good intentions and advice. We believe that nature has given moms the confidence to follow their own path. That's why we support breastfeeding, the best nature has to offer. And that's why we commit ourselves to creating the gentlest nutrition for the most precious little creatures in our lives. Kabrita is made with the natural gentleness of goat milk. It comes with the love of our farmers for their goats, the centuries-old tradition of the Dutch for dairy, and the dedication of our experts for crafting the very best nutrition every day. Because we truly believe this gentle touch of nature makes all babies grow with ease and lets their moms sleep a little better too. Kabrita, gentle by nature.
In the name of Allah, the most compassionate, the most merciful. Our chairman, Professor Wael Bahbah, our guest speakers, Professor Van Plas and Professor Ciel, attending guests for tonight, ladies and gentlemen, good evening. My name is Mohammed Hussein. I am the Chief Executive Officer of Hyproca Nutrition Middle East, and it is my pleasure to be attending with you tonight this event. On behalf of Osnutria Holding BV and its affiliate, Hyproca Nutrition Middle East, I would like to express our sincere gratitude and appreciation for giving us this opportunity to participate in this scientific forum that have came with the support and initiatives in collaboration with the Egyptian Academy of Pediatrics. In this difficult time, I would like to capitalize on the important role of our frontline white coat warriors, whom stand to protect our region and globally from the pandemic COVID-19 disease, which is unfortunately taken off lives of plenty of hundreds of thousands of people. We endorse always that breastfeeding is the best food source for infants and babies, and breast milk substitute are to be used as a substitute, and among the best choices that comes as substitute, the infant goat milk based formula Kabrita. Our company is proud of being among the leading healthcare and baby food global players, whom research, manufacture, and market a range of specialty food products and baby infant formula that is leading all over 70 countries worldwide, from China to Mexico, from Asia till Latin America. We operate with our professional team everywhere worldwide. Hyproca Nutrition Middle East and Osnutria, whom are leaders globally and in specialty infant feeding for more than 120 years, are supporting the pediatric community, scientific research, and pledge to be part of the continuous advancement in scientific research in connection to our babies' health and well-being, where we aim to build a healthy, well-protected, with immunity children. And this is among our utmost priorities. With pleasure, I would like to introduce the chairman of this webinar, Professor Wael Bahbah, President of the Egyptian Pediatrics Academy, for chairing and interrogating this webinar. And I look forward that it will be an interesting and valuable session for all our distinguished audience. Thank you very much. I leave the floor for Professor Bahbah.
And all team of Hyproca Nutrition Middle East and Osnutria for this invitation and this scientific event sponsored by this famous company. Now I am University from Egypt. Now we have two brilliant speaker professor from Europe. We have two large figure. The first of all is the Professor Yavan van den Plas and Dr. Ciel Dilimas. Now we introduce the first one, Dr. Yavan van den Plas. It is a head of pediatric gastroenterology and nutrition department, Kids Health Castle, UZ Brussels. Dr. Yavan van den Plas main interest in gastroenterology and nutrition. Van den Blas today will speak about new insights in pediatric functional gastrointestinal disorder. Welcome, Dr. Yavan. Please, you hear me? Yes. Yes, okay. I see you. Can you speak, please?
Okay, yes.
Thank you.
Good
Thank
evening,
you
everyone. I'm sorry, but the connection is very bad.
Yes, yes, okay. We hear you well.
Shall I
Yeah, we hear you well.
Okay.
We hear you well.
I don't hear you very well at all, but if you hear me well,
Yes, Dr. Yavan.
and
You are with you? You are with Mia.
sorry,
You are with Mia here. Yes? Okay.
you see the slides or?
Okay.
Is this okay to see the slides?
No, please share slides. Yes? Not yet till now?
Share screen.
Share screen,
Yes, share
yeah.
the, yes,
Okay.
yes, exactly.
Yes, yes, okay.
Okay,
Okay, okay.
we are there.
Yes, you are welcome and you can go.
And
You can
now
go now.
I hear you also. Okay, so I'll start the presentation. Welcome you all on this seminar on new insights in pediatric functional gastrointestinal disorders. It's a pleasure and honor for me to present you this topic. The layout of my presentation is after a short introduction, focus a little bit on regurgitation, move to infantile colic, functional constipation, and then focus on the role for goat milk infant formula in the management of those functional gastrointestinal disorders, and then come to conclusions. Before everything, of course, we have to start with a definition, and according to the last definition from the Rome 4 criteria, a functional gastrointestinal disorder is defined as a disorder that after appropriate medical evaluation, the symptoms cannot be attributed to a medical condition other than a functional disorder. But that means, of course, that it depends also on your local possibility to do investigations, and that what you will consider as a functional disorder is maybe different for different places in the world. Another aspect is that whenever you have a disease, such as inflammatory bowel disease or allergy or any other chronic condition, that does not exclude you to have also a functional gastrointestinal disorder. One does not protect for the other. But so important to realize is that if you talk about functional gastrointestinal disorder, you do not talk about a disease. The organ itself is functioning very well. It's the sensitivity of the patient, which is in fact abnormal. The patient is considered hypersensitive. Now, just like in the presentation I'm going to give you, we always consider the different functional gastrointestinal disorders separate. We separate colic from constipation. We separate colic from infantile crying. But in daily life, in fact, the situation is totally different. According to these data from France, from almost 3,000 infants, up to 3/4, 78% of all the infants present with a combination of functional gastrointestinal disorders. So 60% suffers in fact 2 functional gastrointestinal disorders, and up to 15% of the infants present with 3 functional gastrointestinal disorders or more. So it's nice to separate them in scientific talks to make the difference between the different functional gastrointestinal disorders. But for a pediatrician in daily life, most of the children present with that combination of disorders. And it's often not very easy to know if the infant is crying because of reflux or if the infant is having reflux because of the crying. And that's, of course, important to know. On the other side, you may also say, well, does it matter a functional gastrointestinal disorder because it goes over anyway? With time, it disappears, it's not a disease. So why should we bother about it? Well, that's because it does have long-term negative effects. So what this slide shows you is that on the short term, a functional disorder causes feeding difficulties. It's also a frequent cause of stopping preliminary breastfeeding, which we of course should avoid because, as you heard in the introduction, in the movie that you saw, and breastfeeding is of course the best way to feed all infants, and we should avoid unnecessary stopping of breastfeeding. And whenever there are feeding difficulties caused by functional disorders, that causes parental stress and depression. The mother will feel insecure. She's asking herself, what am I doing wrong? Why is my baby so crying? Why is that reflux there? What do I do wrong? So that causes parental stress, but it also has a consequence on the development of the infant, because what has been shown is that a functional gastrointestinal disorder does have behavior and developmental challenges later for the child. And that it has long-term consequences is illustrated in the next image, because even at the age of 3 years and older, the family will still have a different quality of life than if the infant had had no functional gastrointestinal disorder. So the anxiousness clearly continues. And last but not least, a functional gastrointestinal disorder as an infant has also a long-term impact on that infant as later as an adult, because infants and young children with a functional disorder are at increased risk to develop later in life as an adult also functional gastrointestinal disorders. So reasons enough to take it seriously. Now, what about regurgitation and colic? How frequent does it occur? Well, with a group of co-authors, we reviewed the literature, found some nice trials looking at the natural evolution of regurgitation. And in fact, what comes out of it is that 26.7, so 25% of all the infants present with troublesome regurgitation. So one mother in 4 goes to seek medical help because of frequent regurgitation, which makes her anxious. So that's a huge part of the population of all infants. And you may then say, well, these are data from Western Europe, from North America. It's maybe different in other parts of the world. These are data from Jakarta, showing you the red arrow, the orange arrow at the left part of this slide, that 25% of the infants do regurgitate 4 times or more. And that at the red part of the slide, the right part of the slide, sorry, it's about 20 or 25% of the mothers which are anxious because of that frequent regurgitation. So 4 or more episodes of regurgitation and 20% of the mothers seem to be the criterion worldwide for troublesome gastroesophageal reflux. And it's true that it is mainly a problem from the first 6 months of life. This slide shows you the natural evolution, and although you can see that from study to study, the incidence of troublesome regurgitation varies, during the first 6 months of life, it's much more frequent than during the second period of that first year of life. Some infants will still go on by regurgitating, and then almost always it disappears between 12 and 15 to 18 months when the child starts to walk around and becomes more mature. So regurgitation is mainly a problem from the first months of life. But again, it has probably a lifetime long negative effect if you do not manage it appropriately. But this slide shows you data from Australia that if an infant is spilling during 90 days, 3 months or more during the first 2 years of life, and as I already said, that's almost 25% of all the infants, these children do have a greater risk to have reflux symptoms at the age of 9 years. And you see below how frequent that is. It's a factor from 2.3 to 4.7 increased risk factor compared to those who do not have frequent regurgitation to suffer gastroesophageal reflux symptoms at the age of 9 years. So early symptoms predispose the child to symptoms later in life. Now, how do you have to manage that? Well, according to the guidelines and what has been shown in many studies and as shown in this meta-analysis, thickened formula does what it has to do. It reduces overt regurgitation, it decreases the number of episodes of regurgitation, and that's important because that will make the baby more happy, but will also make the mother more happy, and so decrease the negative impact of a functional disorder on the long term. And does that thickened infant formula have very rapidly an impact, or does it take some time? Well, not many studies looked at that, but according to these data from France, it shows you that at baseline, the infants regurgitated 80% of their feedings. So 8 on 10 feedings, there was regurgitation. And then they looked at the efficacy of a thickened formula after 3 days, 15 days, or 30 days. And it shows you that after 3 days, your efficacy is exactly the same as after 2 weeks. So you know very rapidly if your diagnosis of troublesome regurgitation was the right one. After 3 days, you have already a response, which means that if after 1 week the infant is really not doing better, you should look for a different diagnosis. Is it a good idea to give medication to an infant with frequent regurgitation, who cries a lot, who is difficult, who is stressed? What's the effect of omeprazole? This is a study with esomeprazole on symptoms of reflux, vomiting, regurgitation, and it clearly shows you that it just does not work, because the only thing that medication does, that PPI do, is change acid reflux to non-acid reflux, but the number of reflux episodes does not change, so it has no impact on regurgitation or vomiting. The Cochrane review from a couple of years ago confirmed this, and the authors of this Cochrane review concluded that feed thickeners can be useful in term formula-fed infants with troublesome gastroesophageal reflux. So nutritional treatment is certainly recommended. And that's also what we said in our combined European and North American guidelines of the societies of pediatric gastroenterology, hepatology, and nutrition. We said for an infant that is suspected to have gastroesophageal reflux disease, the physician should take history and physical exam, rule out alarm symptoms. So it's important to know the alarm symptoms of gastroesophageal reflux, but that's not so difficult. It's failure to thrive, it's hematemesis, and so it's relatively seldom, of course, in this group of patients. If these alarm symptoms are present, you need to refer the child to a pediatric gastroenterologist. But that will be the case, as I said, in a minority of the children. The vast majority will have no alarm symptoms. And then what do you have to do is continue the breastfeeding, reassure the parents, explain what is happening, explain why the infant is regurgitating, tell the parents that it will go over, and avoid overfeeding, and also keep the baby upright after feeding. And if the child is formula fed, then thickened anti-regurgitation formula does have an indication there, and it will most of the time decrease very significantly the regurgitation and bring reassurance. If that does not help, then you should think about cow's milk protein allergy and manage cow's milk protein allergy appropriately. You can also notice that there is not one investigation recommended here in that first line approach of troublesome regurgitation. It's physical exam, history, and its nutritional treatment and reassurance. What about infantile colic? Well, it's also a very frequent condition, and again, according to the same review of the literature, occurring in 20% of all the infants as medium value, which is again a huge part of the population of infants. What is also important to know is, as I said in the introduction, that there is often a combination of different functional gastrointestinal disorders. And in this study, we looked at it in a different way. We separated the infants with colic and the infants without colic. But then you will see that those with colic have a 2 to 5 times higher incidence of any of those gastrointestinal related symptoms than those without colic. So colic is definitely a high risk condition to develop other gastrointestinal symptoms. And that again confirms the relation between the different functional gastrointestinal disorders. According to the new Rome 4 criteria for clinical purposes, the new definition of infantile colic is an infant of less than 5 months of age, because colic should disappear at the age of 3-4 months. So if it persists longer, it's not colic. With recurrent prolonged periods of infant irritability, fussing or crying reported by the parents that occur without obvious cause and cannot be prevented or resolved by caregivers. So it's an infant that cries for unexplained reasons. And for clinical purpose, you will notice that the rule of 3 hours a day and 3 days a week during 3 weeks has completely disappeared. It's still valid for research purposes, but not for the clinical definition. Just as for gastroesophageal reflux, also colic seems to have somehow long-term consequences, because this looks at a different way. It looks at children which are 8 years old and who have chronic abdominal pain. And then the right part of the slide shows how frequent those children did have other functional gastrointestinal disorders when they were an infant. And again, you will notice that a child with chronic abdominal pain at the age of 8 years at a 2 to 3 times higher risk to have a functional gastrointestinal disorder as an infant. So again, the time relation shows you that functional disorders in infancy do not completely disappear during infancy, because there are long-term consequences and there is remaining high risk to develop functional gastrointestinal disorders later in life. What about the pathophysiology of infantile colic? Well, there are multiple hypotheses, but the last time gut microbiota dysbiosis as being highlighted, together with barrier alterations and mild inflammation, all these causing visceral hypersensitivity. So colic is very common in infancy, has an impact on the well-being and the quality of life of the infant and the family, and as a consequence of that, there are the long-term effects on functional gastrointestinal disorders. And colic also is related to gut microbiota alterations, dysbiosis, as a consequence of that, increased gut sensitivity, and as a consequence of that, or as a cause of that, immunologic pathogenesis, an immature immune system. So it has become clear that children with infantile colic have an abnormal colonization. They have a slower colonization with lower diversity and stability. They have less butyrate producing species, and they have more species that produce gas and inflammation. And they have less lactobacilli and less bifidobacteria, including species with anti-inflammatory effects. So infantile colic is associated with low-grade systematic inflammation. There is also an increased permeability that has clearly been shown for increased transmission of macromolecules such as alpha-lactalbumin. So permeability of the gastrointestinal tract certainly plays also a role. And this slide on fecal calprotectin shows you clearly that infants with colic have increased fecal calprotectin compared to those without infantile colic. Of course, there is huge overlap, but there is a twofold higher level of fecal calprotectin in infants with colic compared to those without colic. Does pain relieving medication make some sense? Well, according to this Cochrane review, there is absolutely no indication for pain relieving agents, no indication for simeticone or any other alternative treatment. Some of the older literature showed that hypoallergenic formulas, so extensive hydrolysates, could be effective in the management of infantile colic. But again, the original data are relatively poor, and there are much more reviews published on this topic than there is original research. And again, what comes out of all these data, they used for the control group other medication, and it shows you that all the rest has no efficacy. Is reflux and acid reflux a possible cause of that infantile crying? Well, the message here is no, because if you look at the slide, there is a horizontal line which shows that there is absolutely no relation between the duration of crying and the fraction of the reflux index, so the percentage of time that pH was below 4 during pH monitoring. So you have infants who have severe acid reflux who do not cry at all, and you have infants who cry for hours and who have a completely normal pH monitoring. So an infant with reflux disease very often cries, but an infant that cries without regurgitation or without vomiting very rarely will have reflux disease or acid-related reflux disease. And we just have a paper which came out which showed, in fact, that in infants, non-acid reflux is causing much more distress and much more pain than acid reflux. So according to literature, there is no effect of proton pump inhibitors on crying and irritability of infants. And PPIs are not devoid of adverse effects, as shown in this slide. Chronic use of PPIs in the left top of this slide is associated with small intestinal bacterial overgrowth, occurring in 25 to 30% of all the infants on PPIs, causing gasiness, crying, distress, exactly the same symptoms as the symptoms for which the PPI was prescribed. But for us pediatricians, what is also very important are the nutritional adverse effect of PPIs, because there is a decreased nutrient absorption. There is a decreased absorption of calcium. Infants on PPI have a higher risk to have bone fractures later in life. There is a higher risk to have an iron deficiency and anemia, and there is a higher risk to develop vitamin B12 deficiency. So according to this meta-analysis performed by someone from Mexico, there is clear evidence that Lactobacillus reuteri is effective in the management of infantile colic, but that's limited to the breastfed infants. There is quite some literature that this probiotic is effective in crying, reducing crying in infants which are exclusively breastfed, and that for formula-fed infants, dietetic interventions are also quite effective, and that all the rest is not effective at all. And you can see in the middle of the slide at the bottom that drugs are not effective at all. The next functional disorder is functional constipation, occurring in 10 to 15% of all the infants, a little bit less than the two others, but still quite frequent. How to manage functional constipation in formula-fed infants? Well, this is a study with a partial hydrolysate, but also reduced lactose, and with, that's important, with prebiotics, and which is palm oil free, and with the fatty acid on the SN2 position. And you see that there is an increased defecation frequency and a decreased defecation consistency. So prebiotics and palm oil free formula are effective in the management of infantile constipation. And that's because most of the formulas contain fatty acid in the SN1 or SN3 position. And then those free fatty acids, as is the case in palm oil, in combination with calcium, cause the formation of calcium soaps and hard stools. And so lipids in the SN2 position, as highlighted in this meta-analysis, are very effective in the management of infantile constipation. So that brings me to the possible role of goat milk infant formula as a formula for infants and its role in the management of functional disorders. First of all, it was 2013, 2014, when the goat's milk-based infant formula was accepted by the European Food Safety Authority as being absolutely safe and got a positive advice. And goat milk as a protein source in infant formula is approved in Europe since 2014. Is goat milk infant formula nutritionally adequate? Well, as shown in this slide, at least 3 different studies have been performed in different parts of the world. And the conclusion is that goat milk infant formula provided completely normal growth and nutritional outcomes that did not differ from the growth of the traditional cow's milk-based infant formula. So infant formula based from goat's milk or cow's milk is nutritionally equivalent, and infants grow very well. What is different is the protein quality, because protein quality itself is maybe not different between goat, cow's milk and human milk, but the kinetics of protein digestion of goat's milk differ from the kinetics of protein digestion of cow's milk, and that of goat's milk was much closer to that of mother's milk. And that's because goat's milk contains almost no alpha S1 casein, which may improve digestibility, as shown in this slide. So these data show that the proteins, the casein, whey ratios, and especially the kind of caseins in goat's milk are different from those in mother's milk. And this explains, these differences explain why you got difference in digestion of cow's milk and goat's milk, and why goat's milk is better tolerated than cow's milk. And this is shown in this slide, where in fact you see the digestibility in 3 different lines, and the top line is breast milk. Just below that you have the goat's milk, and then the red line is cow's milk, and you see that how much protein is digested is much slower for the cow's milk based infant formula than for the goat's milk based infant formula, and that goat's milk based infant formula is much closer to that of breast milk. So the beta diversity of the total microbiota, we move from protein now to the microbiome, is also different for cow's milk or goat's milk based infants, fed infants. So the beta diversity analysis of the total microbiota sequences of different microbes revealed that they were more similar in breast milk, goat's milk, compared to breast milk, cow's milk. And that's maybe related to the fact that goat's milk does contain much more prebiotic oligosaccharides than cow's milk. Of course, now infant formula is very often supplemented, but natural goat's milk contains 10 times more prebiotic oligosaccharides, still much less than mother's milk, but definitely more than cow's milk. And so the presence of those quantifiable oligosaccharides in infant formula is important because they are naturally present in goat's milk infant formula, and they exhibit a strong prebiotic and antipathogenic adhesion properties, and may therefore confer gut health benefits to infants. So this study also looked at the oligosaccharides in goat's milk-based infant formula and their prebiotic and anti-infection properties. And the conclusion of these studies is that these results suggest that the oligosaccharides naturally present in goat's milk-based infant formula exhibit strong prebiotic and antipathogenic adhesion properties and may therefore again confer the gut health benefits to infants. And into Kabrita formula, there is prebiotic galacto-oligosaccharides added in on top of that. And then there is the difference in lipids. So the importance of beta palmitate, I highlighted that when I discussed infantile constipation. The goat's milk infant formula contains beta palmitate, which is much closer to the lipid content in mother's milk, which is also beta palmitate, so in the SN2 position, where for most cow's milk based infant formula, the palmitate is in the SN1 or SN3 position and then forms those calcium soap. And so what this slide shows you is that the right part is light blue, is breast milk, so the breast milk fed infant. The dark blue is with the higher levels of beta palmitate, and then in gray, it's the low levels of beta palmitate. So if you want, the dark blue is the goat's milk based infant formula, and you see that for all these parameters, the goat's milk is much closer to the result, to the outcome in the breastfed baby than the cow's milk based infant formula. Which brings me to conclusion that for functional gastrointestinal disorders, of course, parental perception is an issue. There is on the other side, the medical reality. So reassurance, anticipatory guidance, explanation to the parents about the reason and the prognosis of the functional disorder, and explaining also that there is no disease will help in reassuring them and will help in decreasing the impact on the functional gastrointestinal disorder. There is no doubt that breastfeeding is absolutely the best way to feed all infants, and a functional gastrointestinal disorder is almost never a reason to stop breastfeeding. So time is the cure for functional gastrointestinal disorder. You need to win time, and because it will go over with time. So reassurance will certainly help, but dietary treatment does have the advantage to be effective and to be very safe because there is no disease, so there is no indication to give drugs, to give medication. And you should postpone medical treatment as long as possible. Because on the one side, it makes no sense because medication is there to treat disease and there is no disease. And all medication does have adverse effects, while you have a dietary treatment, which is effective according to literature and which is of course safe. So what do we have to do as a healthcare professional whenever we see an infant and parents who consult because of a functional disorders? Always educate and reassure, and then use nutritional management to reinforce our reassurance. And that will result in an infant making it symptom-free and happy, which will result in less clinical consultations and less healthcare costs. And we'll finally make the parents very happy, and at the end make the doctor very happy, because if the mother is happy, the doctor is also happy. For all those functional gastrointestinal disorders, certainly for colic more than for the others, microbiota development plays also a very important role. But healthy digestion needs a healthy microbiome. And again, the prebiotic oligosaccharides, which are naturally present in goat's milk, therefore are different from raw cow's milk or natural cow's milk. And that microbiome is not only important for a healthy digestion and absorption, but also for a healthy development of your immune function. And also important for the gut-brain crosstalking, because there is a relation between the microbes in your gut and how your brain reacts to that. So gut-brain crosstalking is very important, and dysbiosis does cause pain, does cause feeding problems, and a healthy microbiome is related to a much healthier eating and healthier baby. Functional gut microbiota. What are the gut microbiota? What are the functions? Well, you see them listed here. So it's very important to have a healthy gut microbiome. And so to give an infant formula which is enriched with oligosaccharides in order to help to develop that very healthy microbiome. And with this last slide on the microbiome and the important effect of that, and the impact of goat's milk possibilities on the management of functional gastrointestinal disorders, I would like to thank you for your attention and try to answer your questions if you have some.
Thank you, Professor Van den Blas, for this. Sorry, you hear me?
Yeah, I hear you.
Yes, thank you, Professor, for this excellent illustrative presentation. This as usual.
Thank you very much.
Please, we have 55 questions.
Yeah, I see that.
Yes, you see. We will try to select some of them, and in the webinar we will discuss again.
Okay.
The next one, what if the infant can't tolerate hypoallergenic and extensively hydrolyzed formula because of unacceptable taste?
Yeah, well, that's certainly an issue that hydrolyzed formula do have a bitter taste, but I would, on the other side, like to highlight that goat's milk infant formula is not an alternative for the treatment of cosmic protein allergy, because there is 80% cross allergenicity. That means that 80% of the possible allergenic peptides are exactly the same in cow's milk than in goat's milk. So it's true that if you have a child which is allergic to cow's milk and you go to goat's milk, it will be effective 2 times in 10, but not effective 8 times in 10. And that's much too low to use it in the management of cow's milk protein allergy. So it's certainly a shortcoming of hydrolysates, that they are expensive, that they have a very bad taste, but goat's milk is no alternative for that management.
Okay. Second one, why children with colic has sleep disorders later on during childhood?
Yes, well, that's the interesting question, and that's what I tried to highlight in the presentation, is that previously we tried to banalize functional gastrointestinal disorders in infants because regurgitation stops at 6 months, and the crying stops at 4 months. So what should we bother, because it all disappears? It's not really true. If you look at literature, it does have long-term consequences, and somehow those children with colic have sleep disturbances, have more behavior disorders later in life. Now, what we do not yet know is, can we manipulate that? That is not clear. It's not clear that if we manage the infantile colic appropriately and prevent or decrease the crying very rapidly, that does also have a positive effect later in life. The same is true for reflux. We don't know if treatment of regurgitation changes the outcome later in life and decreases the incidence of reflux symptoms later in life. I'm more favorable to think that appropriate management of colic might have a long-term beneficial effect, because that's related to the microbiome. And the moment to change that is during the first 2, 3, maximum 6 months of life. And then you get your final microbiome. And so if you have a healthy microbiome early in life, that may have long-term consequences, because behavior problems are related to your gastrointestinal microbiome. I'm not saying it's causal, but we know that children with autism spectrum disorders, with attention deficit disorders, do have a different gastrointestinal microbiome. But it's too late then. Changing the microbiome does not treat attention deficit disorder, does not treat autism, but maybe if we induce a healthy microbiome early in life, that we can have an effect. But that needs to be investigated.
Okay, another question from the same doctor, Dr. Khalab Gargri. The only rule of probiotics are: the animals reduce crying in both breast and bottle feed babies. Rotary is the beneficial in breastfeed baby, not bottled. What's your opinion about that?
Yeah, well, it's true that the studies have shown no efficacy in formula-fed babies, and maybe the reason for the crying in formula and breastfed babies may be different. That to me seems one of the explanations, but that has not been really looked at, because up to now there were no microbiome analysis done in those colicky babies treated with Rotary or with placebo, and see then if you have a different outcome.
Yes, okay. Another question: does the goat milk has a role in infantile colic?
Yes, well, I think so. I try to highlight that probably not for regurgitation, because it's not thickened, and I think that thickening is the major way to treat regurgitation, because you change the microbiome, easily digested, and because constipation, less hard stool, in infantile it could certainly be beneficial, and maybe a little bit of, but that should be.
Does Gaviscon can be used?
Well, Gaviscon alginate, yeah, of medical treatment. In the NASPGHAN guidelines that said all for Gaviscon side as primary, and a Cochrane review concluded trial of Gaviscon, and the NICE guidelines from the UNOM also concluded that there is an indication to try Gaviscon alginate for 2 weeks. So I think for the management of reflux, troublesome regurgitation, thickened formula, if that does not help, go to the extensive hydrolysis, or think about cow's milk allergy, and if that does not help, give alginate a chance. But try to stay away from the protopump inhibitor.
Okay. Another question: would you advise use of infant formula with a low or total absent lactose for the rest period of feeding, or just as a temporary solution for a short period, as we are aware of how much lactose is important to infant health and well-being?
Yeah, well, lactose is the most important carbohydrate in mother's milk, and primary lactose intolerance does in fact not exist. I think there are 11 or 12 cases reported in the literature, and 8 of them come from Finland, so we never see that. Lactose is an important carbohydrate, and whenever it's not well absorbed, it acts in fact as a prebiotic, because then it's fermented in the colon, and so lactose does have prebiotic effects, and is therefore important for the development of your balanced gastrointestinal microbiome. So overall, I think that it's best preferable to give infant formula, infant feeding with lactose, because if, again, lactose, healthier microbiome, you get also better calcium absorption. So it has certainly also positive nutritional effects.
Okay, another question. HMOs is a big news nowadays.
Yes.
And from HMO's point of view, is it better to use cow milk reinforced with 2 or 3 HMOs, or better to use goat milk? This is a
very good question. Now,
this is a very good question. Okay.
I think we know that there are about 150 different human milk oligosaccharides in mother's milk. Yes. And what industry can do now is indeed make in a factory 2 or 3 of those human milk oligosaccharides exactly the same as they are present in mother's milk. So that's the positive point of it. But we add 1 or 2 or 3 out of the 150. What you do with galacto-oligosaccharides, which is also added to the goat's milk infant formula, is it has those oligosaccharides do have a different structure than the structure of the human milk oligosaccharides. But GOS galacto-oligosaccharides, it's not one molecule that you give, it's a spectrum of 100 different ones. So from the variation point of view, you're much better off with fructo-oligosaccharides or with galacto-oligosaccharides, because it's closer to human milk oligosaccharides from the point of view that you give 100 different molecules, as is the case in mother's milk. From the structure point of view, your artificially made HMO is identical to the one in mother's milk. But I think that from the clinical point of view, no one has shown that addition of HMO is clinically better for the infant than addition of galacto-oligosaccharides.
Okay. Are all goat-based formula similar to whey to casein ratio in breast milk? This is another question.
Well, goat's milk infant formula has the same ratio of whey casein as the modern cow's milk-based infant formulas, which is close to the ratios as in breast milk. And the difference is there that caseins from goat's milk differ from the caseins from cow's milk, that the casein from goat's milk seems to be closer to that in breast milk than that from cow's milk.
Yes, okay. Another question, what is the nearest to human milk from histolytic view? Is it cow or goat milk?
Sorry?
What is the nearer human milk?
Okay.
Cow or goat milk? This is another question, yeah.
Well, I think that goat's milk, I would respond it in a different way. Goat's milk is certainly not further away from mother's milk than cow's milk-based infant formula. So I think it's quite similar, but goat's milk has its advantages over cow's milk for different components, as I tried to explain. So there is certainly no reason to think that goat's milk is not an appropriate infant feeding.
Yes, okay. What another question? Probiotic overuse and overdose side effect, and for how long it can be used?
What? Probiotic?
Is about, yes, probiotic. Sorry.
Okay.
Excellent presentation course. Prebiotic and probiotic is very helpful for helping in improving FIG. My question is about probiotic overuse or overdose side effect and for how long it can be used.
Yeah.
He asked about probiotic overuse and overdose.
Yeah. Well, in general, you have to give a lot of probiotics to really give an overdose. If you really take too high dose, you may have adverse effects such as diarrhea, but that's really the exception. In general, when you take infant formula enriched with probiotics, it's considered to be safe. But I think that the concept is totally different. And for me, I think that prebiotic is much more relevant because it changes the microbiome of the host itself and has a much more broader effect. And with probiotics, you only give one strain or two strain or at the best 5 or 6 different strains in combination products. So probiotic is more for treatment of acute disease. For instance, infectious gastroenteritis, there a probiotic may be a very good indication. While for broader indications like colic or whatever, prebiotics seems to be more a better idea, and certainly in prevention, prebiotics are much better than probiotics, I think.
Okay, another question, cow milk protein allergy and the goat milk based formula. What's your opinion about this?
Yeah, well, that's what I said in the beginning, that goat's milk is not an indication in cow's milk allergy.
Okay. Do you expect the oligosaccharides in fresh milk will not be inactivated during milk processing?
No, prebiotics are not deactivated. They do not change during the making of infant formula. And so that's another advantage of prebiotics, is that it's not so much dependent on environment and technology and survival. And certainly in countries like yours, where it can be very hot, probiotics may have difficulties in surviving, where you do not have at all that issue for prebiotics.
Yes, okay. AR formulas in GERD. Use of AR.
Yes, well, I think that's if there is reflux, even troublesome reflux, nutritional treatment is the first line of management. And protopump inhibitors are in theory indicated to treat erosive esophagitis, but that means that in fact you need an endoscopy to have the diagnosis. So I think we should much more use nutritional treatment, thickened formula, than drug use for reflux disease in young babies.
Okay. Another, does maternal diet has a relation with FIGDS or not, especially colic? Maternal diet and this.
Yes. Well, overall, I would say no, on condition that the mother has herself a very diversified diet. So you should take a dietary history to see if the mother is not eating all the time something which could cause fermentation. We had recently a discussion about mothers eating many nuts, and that was related to colic, but then it's mothers who replace whole feedings by eating only nuts. So I think overall, a diversified diet is very important. And then one of the causes of infantile colic is cow's milk protein allergy. If you really think in a breastfed baby that a colic could be caused by cow's milk allergy, put the mother on a cow's milk free diet for 2 weeks and see if it brings improvement or not. And if you prolong that elimination diet, then you should prescribe calcium to the mother, because that's the reason why she needs to drink milk, is to have calcium intake.
Okay, another question, how to consider folic acid deficiency with goat milk intake? Also the cross allergenicity with cow milk.
Yes, but it's true that you have that problem with raw goat's milk, but the infant formula has been supplemented, so there is no issue at all. There is no safety issue at all, because the infant formula goat's milk contains all nutrients that the infant needs.
Okay. In case of severe GERD in 7 months old, can we doubt the dose of BBI?
Can you double?
Double, yeah. The dose of BBIs.
Well, yeah.
Sorry.
I think if a normal, first of all, think twice before you start PPIs. Secondly, if you start at PPIs and it does not help, it makes probably no sense to get to higher doses, because if you look at pharmacokinetic studies and compare the dosage that we give in infants and children compared to adults, I mean, a 10 kilogram baby gets 20 milligram of omeprazole, which is the adult dose. So we give already huge doses of proton pump inhibitors. So if it does not work, it means that acid reflux is not the cause of the crying.
Yes, okay. Another one, sorry. If there is recent guideline to differentiate between cow milk protein allergy and the cow milk intolerance, or it is still not unclear yet? This is a recent question.
Yeah, that's the $1 million question.
Yes. Intolerance and allergy.
Yeah.
What is the difference between the two meanings? Cow milk intolerance and cow milk allergy.
Yeah. Well, I think you have two types of cow's milk allergy, IgE mediated and non-IgE mediated. And the IgE mediated, that's relatively easy to recognize, and you have the IgE that you can measure and you get your diagnosis. The issue is non-IgE mediated allergy and intolerance, or call it functional disorder. I mean, I don't see how you can easily separate in a clinical situation a functional disorder from a non-IgE mediated cow's milk allergy, or intolerance in the sense that it means symptoms caused by the ingestion of cow's milk protein. And that's because your management, your diagnosis of non-IgE mediated cow's milk allergy is you take the cow's milk away and you challenge and the symptoms reappear. But that will also happen if the cow's milk is causing a functional disorder, or if it's intolerance, because to manage that, you take the cow's milk protein away, the symptoms disappear, and then you give it again. So it's very hard to make the difference. And I don't know if it's really important, because the allergic march is mainly related to IgE-mediated allergy, and non-IgE-mediated allergy, the children most of the time become tolerant around the age of 1 year. So also the natural evolution where the functional disorder disappears between 6 months and 1 year, it's the same from the non-IgE-mediated allergy.
Yes, by another way, is the goat milk has a role in cow milk intolerance, not allergy.
Well, I think that could be a very good way to make the difference between functional disorder and allergy, because as we said, if it's allergy, it will not be effective, while because of better digestibility, etc., it may be effective in the management of the functional gastrointestinal disorders. Absolutely.
There is a lot of question. We have 101 question, which it is too large to discuss.
We have to till Sunday.
Yes. We can. Is there any allergy from a goat formula?
Yes, of course.
Yes.
So it's the same as for cow's milk protein. It's about 2, 3 to maximum 5%, but you can be allergic to goat's milk protein. Absolutely.
Yes, there is a relation between H. pylori positive and the type of feeding, and what type of feeding should be restricted to child?
No, I don't think that there is a clear relation between feeding and H. pylori.
Yes. Also, what's your opinion about the last algorithm published by Nasopharyngeal and Epidemiology regarding the GERD treatment?
Yeah, well, as I highlighted on your question on alginate, I follow the guideline for thickened formula extensive hydrolysate, but then I would give alginate a challenge. Why in the guideline of Nasopharyngeal and Epidemiology, it's mentioned to not give it because there was absence of evidence. But as I tried to explain, that contradictory advice comes from what you decide as your primary endpoint when you do your meta-analysis, whether you will find efficacy or not. And so Cochrane and NICE guidelines and did find effect for alginate, and there is recent literature that also showed efficacy. And there is a lot of literature in adults that alginates are very effective in those patients with a gastric acid pocket. So acid which is on top of your stomach, and alginate is there much more effective than protopontin inhibitors.
Yes, okay. Another question, is comfort formula help in colic or partially hydrolyzed formula? Or goat formula, based formula?
Yeah, well, it's colic is multifactorial, and I think what there is in literature is that different dietary treatments may be helpful, and it only shows that intact cow's milk protein is very often a cause or related to infantile colic or crying, and because of the better digestibility of the goat's milk formula, it does have an indication in the management of infantile colic, while there is also literature showing that extensive hydrolysates are sometimes effective, and that partial hydrolysates with reduced lactose but with lactose and beta palmitate can also be effective. Yes. There are no comparative trials, so you cannot say one is better than the other.
We have a lot of questions, but we have over 104 questions. We will postpone another to the end of that. Thanks a lot, Professor Van Blas, for this excellent presentation and the conservation.
Thank you very much.
And now we will say about there is a CME accreditation from the American Association for Continuing Medical Education presented by Kabrita to all doctors attendees in this webinar. And now we will go to a small video for Kabrita, then we will go to Dr. Sil. Thanks, Professor, thanks. And we want you to be with us, yeah?
Yes, thank you.
We will
I
ask
stay with you.
another question at the end of the webinar.
Absolutely, promised.
Yeah, thank you very much. Thank you very much.
See you later.
Yes, okay, thank you, bye.
Babies are born to be at ease. Nothing lets babies grow more at ease than their mother's love. But moms find it hard to follow their intuition when facing so many good intentions and advice. We believe that nature has given moms the confidence to follow their own path. That's why we support breastfeeding, the best nature has to offer. And that's why we commit ourselves to creating the gentlest nutrition for the most precious little creatures in our lives. Kabrita is made with the natural gentleness of goat milk. It comes with the love of our farmers for their goats, the centuries-old tradition of the Dutch for dairy, and the dedication of our experts for crafting the very best nutrition every day. Because we truly believe this gentle touch of nature makes all babies grow with ease and lets their moms sleep a little better too. Kabrita, gentle by nature.
Now it is the time for the second brilliant professor, Dr. Sil Dalimans. Dr. Sil Dalimans will speak about the new era, new updates in COVID-19. Dr. Sil Dalimans, it is a consultant pediatrics, pulmonology, and infectious diseases, Kids Health Castle, UZ Brussels. You will speak about COVID-19 in children, European experience. Welcome, Dr. Sil.
Thank you.
Welcome. Happy to see you and happy to be with us in this webinar.
Thank you.
Thank you. Welcome.
Okay, thank you. I would like to talk about Corona, a hot topic for the moment. But I will first tell you something about myself quickly. I am young. I hope you can see that. So I'm a young resident in, not a resident in the English way. I'm a consultant in the English way. So I'm a young consultant who is at the moment part of Professor Van der Plas' team, and I'm specialized in pulmonary and infectious diseases in Belgium. That is a combined specialty. And I focus on infectious diseases, and I am, for our hospital, mostly coordinating all the corona-related matters since the crisis started. And so I am quite up to date in what is going on about corona. And so I wanted to give you an update. First of all, the COVID-19 pandemic is an international crisis. It's an emergency situation of healthcare, but also with a lot of economical impact, which is evolving very rapidly. And the knowledge about corona is also evolving very rapidly. And so everything I say today could maybe still be true or not be true in a few weeks from now, if more evidence comes out. The problem with the evidence there is today is that there is no high quality evidence. Everything is published very rapidly. Everything is based on epidemiologic and retrospective cases. And so there is often peer review done for everything that is published, but it's often not edited well. And so we often see articles being published who still have spelling mistakes. And so we also see that the way studies are performed is not always in the best evidence. And that makes it extra difficult to come with guidelines. And that's why a lot of the things I'll say are based on little evidence. It's very important to know that and to consider that and that it's evolving rapidly. And so don't trust everything I say. Important also is that, first of all, we should not harm.
Dr. Seal?
Yes?
Sorry, can you raise your voice, please?
Yes, I can try to even raise
my... Because the volume is low.
Okay. Can you hear me better now?
Yes. Okay.
Okay.
Thank you.
Okay. This is the overview of my presentation. So I will discuss a lot of interesting topics. We'll start with what is corona exactly, how is transmission, what does this implement for personal protective equipment, what about epidemiology, clinical features, and then we focus on pediatrics, of course, diagnosis, therapy, also with a focus on children. I have some small conclusions and I'll show you my references. The coronavirus is the SARS coronavirus 2, which with SARS standing for severe acute respiratory syndrome. It is part of the family of the coronaviridae, and you have a picture here which shows you why it is called like this. It's a very small virus, which is an RNA virus with a crown-like appearance because of the spike proteins that are on the outer cell membrane. And so when you look at it under an electron microscope, it looks like it's wearing a crown. And that's what the name comes from. We already know this virus, this family of viruses since a long time. There are 4 subgroups of this virus. There is alpha, beta, gamma, and delta. The beta coronaviruses are, we already know a lot about, is the SARS coronavirus that was an epidemic in 2002 and the MERS coronavirus in 2012, which most of the public will probably know better than me because it was the Middle Eastern respiratory syndrome virus. This coronavirus, the COVID-19 coronavirus, is a novel stem that was discovered in Wuhan in China. And it probably originates from bats. That is based on the discovery that was in a food market, and maybe not directly through bats, but maybe bats that gave it to other animals, which then gave it to humans. What is interesting about this is that this spike protein that gives it its appearance with the crown-like appearance also interacts with ACE2 receptors. We know ACE from ACE inhibitors, which are used for cardiovascular disease. These ACE receptors, ACE2 receptors, are present in alveolar epithelial cells, so in the lungs, but also in the small intestines and also in some smooth muscle cells. And if it's true, this spike protein, that it interacts with the ACE receptor, which then leads to cell invasion, which then leads to the coronavirus disease 2019. And that's what the name COVID-19 stands for. The transmission is human to human for humans, except that it came from animals. But now mainly the source of transmission is from one human to another, and mostly through droplets and contact. So it is not an airborne disease. And that is very important because airborne diseases like tuberculosis or like varicella zoster they can stay viable in the air for a very long time, and they can be transmitted when coughing for much longer distances than droplet contamination. So the most droplets are if somebody coughs droplets are spilled, they can be contracted by somebody else if you are standing quite close, because droplets are, they have a weight. They are not transmitted very far, and they drop to the floor or to any surface that is there. The contact is probably also a very important way of transmission, because they stay viable on surfaces for quite a long time. And that makes it very important that people hand wash that much, because when you touch something that somebody just coughed on and that contains droplets, and then you touch your nose, your mouth, any mucosa, also your eyes, you could still, contract the disease.
Excuse me, doctor, please.
Yes.
The voice again.
Sorry.
We need to raise, yeah. You can speak without a headset. You can speak direct to the laptop. Yes. No. No.
Better now?
Yes. Okay. This is good.
Okay.
Yes.
Okay.
We hear you, Gwen.
Fomites, I wrote that name, is what we call objects that can transmit or can contain droplets of a disease, and so be infectious in a way or contagious in a way. What is difficult about the difference between droplets and airborne disease is that we know that this virus can stay viable in aerosols for 3 hours, which is quite long, and which was the reason for which there was first an suspicion of airborne disease. So the half-life is quite quick. So after those 3 hours, there is already a big part of the virus that is gone. And they did a study in Singapore who did samples in patient rooms on contact surfaces and in the air, and everything was negative in the air, and on contact surfaces it was positive if not cleaned, but negative if routinely cleaned. And so that's why all the recommendations are that important, that everything should be cleaned well and we should hand wash a lot. And that's probably even more important than wearing masks, and also the social distancing of 1 meter, 1.5 meter is out of the same idea that you will not get infected if you stand a few meters away from somebody who is coughing. So this implements for personal protective equipment in the hospital that we should protect for those two things. So droplet and contact if we have a normal contact with a patient that is suspected or confirmed. The droplets can be through glasses. You can wear your own glasses, although there are some sideways where you can still be infected, or protective glasses, and a normal FFP1 mask. That's a surgical mask or mask that nurses wear. And for the contact, you wear gloves and you protect your clothes because of the contact and because to not make your clothes a fomite. But during aerosolizing procedures, when more droplets are produced in the air, for example, when you do a bronchoscopy, when you do respiratory physiotherapy, when you do a nebulization, when in a child you do some rinsing of the nose, then droplets are probably sent in the air, even in smaller droplets, and that could make them go further or be more contagious. And one of the very important aerosolizing procedures is intubation. You stand very close to your patient, you irritate the throat, there will be a cough reflex, and there is more risk that you get infected. And that is why during those procedures, there is recommendation of wearing FFP2 mask, that is this duck face mask. And very important to have the protective glasses or wear a face shield. And so in most hospitals where people are treated for corona, for COVID-19, there are different kinds of isolation in place. And in an intensive care unit, it will be way more aggressive, more personal protective equipment than in normal ward. Very important is that all these materials are correctly used, because you can contaminate yourself if you touch your mask from the outside and then touch your eye, touch your nose, do something else. And if you take off your clothes, it's your gown, it is important that you don't contaminate your own clothes, because then again, if you touch it after, then touch your face, you might get infected anyway. So that's why it's very difficult to make any recommendations for the general public to wear masks, for example, because it does protect in a way, but if you use it incorrectly, it might even be more dangerous. If you use if you wear a mask and then touch it the whole time, you probably better don't wear a mask, and then you might be safer. It depends on how well you know how to use it. A word about epidemiology. So the whole epidemic started in Wuhan, in China. As you can see here, there is a map that shows us how much COVID-19 is diagnosed around the world. And as you can see, there are some blind spots, some big red spots in the East, a lot in Europe, also in the Middle East, and also in the USA. In total, today, there are more than 2 million confirmed cases and almost 150,000 deaths all over the world, with a lot of people already recovered. And probably this is an underestimation of the real cases, because this only counts confirmed cases, and it depends on how you test to see how many people are actually involved. I'll tell more about that a little bit later. So you all heard about the concept flattening the curve. It's shown in this graph that what we see in an epidemic is that a lot of people get infected very quickly, and you get a peak in how many people are sick at the same time. And what you want to do is you want to try to have less people infected and also spread it so that your healthcare system capacity is not over demanded. And so you hope, if you can stay in your healthcare system capacity or under the line, that you will manage to save more people. Because if you cannot give them access to healthcare, there will be more mortality or morbidity. The problem is, if you can see, that the time for the epidemic takes longer. So there will be a longer time that the coronavirus is still present in your community. How can you try to flatten the curve to avoid transmission as it is the only protective way? And very important is the social distancing, and that refers to how the virus is transmitted. So it's transmitted through droplets and through contact. So if you stay away 1.5 meters or more from other people, you can probably not get contaminated if you don't cough in each other's face directly. And then also your hand hygiene, your cough hygiene is that you should cough in a clean towel, throw it away every time, or cough in your elbow. Wash your hands very often, clean surfaces a lot, and stay as much in your home as possible. How are we today? So these are the curves of the most affected countries. The first peak that you can see in February was in China, in Wuhan. And then there was the orange line coming up, that was Italy, followed by Spain. And then you see the USA rising and in numbers exceeding everybody else. So in China, we could say their curve is flattened now compared to what it was in February. And they took very quick and effective measures of social isolation and quarantining. In other countries, we might say it's starting to flatten or starting to diminish, but in the USA, we are not there yet at all. And so on global level, the amount of people is still not going down because of the USA having this very high rise. Important for us, especially as pediatricians, is the age. These are numbers from Belgium, but it's comparable in every country, and all over the world it's the same. We see that not a lot of children are affected by the virus. There are not a lot of cases. This is information from a few days ago on the left side, which says that in Belgium there are about 400 cases in children, and that are the confirmed cases, and a lot more in adults, and especially in elderly people. If you see on the right side, there is, I find it a bit easier to see that especially older people are contaminated, but you see under 20 years are almost not affected. And there is a male predominance, which is not explained until today why that is. There is no clear hormonal theory or anything else that can explain why males are more affected than females, but we see it in Belgium. We see it everywhere in the world. The reason, if you compare the left slide, the left graph to that you see that the male-female ratio is seems to be that there are more older females affected, but the only reason is that females live longer. And so there are more females in those age groups. But in general, males are more affected. The mortality, on the left side, you see a graph that shows that Belgium has the highest mortality of the whole of Europe at the moment. This is also dependent on how you count. And so it depends also on how many tests you do and how much diagnosis you have, because a lot of people are also dying in the community. And it depends, for example, in the beginning, Belgium's mortality was not that high, but there was no testing in elderly homes. Now they introduce testing in elderly homes, and they know there are a lot of people in elderly homes dying when they have coronavirus. The case fatality rate, which is explained, so on the right side, you see that it depends also on how severe your disease is. These are estimates which are changing the whole time. So don't fix on the numbers itself, but it's about the proportion in general. There are not a lot of people in the ICU, as you can see in the pyramid. It's only the top of the pyramid. So only a small proportion of people getting sick will be in ICU. But of those people, a lot of them are dying. The less sick you are, the less you are dying. This is what we see in a lot of diseases. It's not a surprise, but it's important to know that, for example, in Belgium, since a few weeks ago, we only tested people who were hospitalized or in ICU. And so it's only the top of the iceberg that is tested. And so the confirmed cases are a small proportion of the total number of cases, because a lot of people are sick, are sent home because they are fine. They don't need hospitalization. They conquer the disease themselves, but they are, it's also only an estimation how many people that are exactly. And then there is an important group of asymptomatic people, which is even more difficult to see or to know how many people this is. And that is also dependent on if you screen and so test people who are not sick, or if you don't. And in most countries, and also in Belgium, you don't screen. It doesn't really matter in general, because you don't have to know it, especially not when everybody is trying to stay at home. But it is difficult to draw conclusions on that, especially evidence-based conclusions, because everything is based on estimates and statistics. And there can be faults in that. The most important message about mortality is that it is very age dependent. In China, there were no under 9s, no under 10-year-olds that died during the pandemic and well, during the epidemic in China. And in general, the right side shows you the numbers of Belgium. So also in Belgium, we don't have any children who have confirmed coronavirus who died. And there are, we see the same in a lot of countries. So there are some children who died with coronavirus in general, but it's a very small group, and it's very reassuring as a pediatrician that this is not affecting our kids. The clinical features. So these are definitions from Belgium, but they are European actually, and they are also used all around the world. There are possible cases is somebody who has new complaints of an upper or a lower respiratory tract infection or a deterioration of chronic respiratory symptoms. And so that is a lot of people. Everybody with a little sneeze or a little cough is a possible COVID-19 case. But not everybody of those cases has COVID-19, and especially in children, we think probably a very small proportion has it. A radiology confirmed case is somebody whose PCR test is negative, but clinical features and chest scan are suggestive. And so these were in the beginning not counted as confirmed cases, but they are counted as confirmed cases now, which also means that our numbers of total confirmed cases are rising. A real confirmed case, laboratory confirmed, is a person with a positive PCR on nasopharyngeal swab. What is the presentation in children specifically? So we know in adults that a lot of them have mostly a dry cough, fever. They can complain of general malaise, like in influenza, some myalgia, a sore throat, some runny nose, but not much. But in children, we don't see a lot of fatigue like we see in adults, especially not in small children. And we can see some gastrointestinal symptoms, which are not often present in adults. And so that's important to know too, that although coronavirus is primarily a respiratory infection, it could also be the cause of a gastroenteritis. And so every gastroenteritis should also be a suspected corona case or COVID-19 case in children, which is not in our definition, but that's because the definition is in general and it's mainly focused on adults. If we look at how the blood tests are responding, we know from adults that a lot of them have high lymphocytes and CRP elevation. In children, we see mild changes, but not corresponding very well to what we see in adults. X-ray often doesn't show anything, and CT scans, so chest scans, are very often normal, even in confirmed cases. So 33% of them are normal. And that means that it's, for children, not so easy to have a radiologically confirmed case. And so probably we have to look at COVID-19 differently in the pediatric population. A bit more about this radiology. In adults, it is considered very sensitive. It's not specific at all. It only gives an idea of a viral infection. But if you are in an epidemic, you can assume that if you see a virus, that the risk that it is the virus of the epidemic is that high that it could be seen as an accurate way of diagnosis. The lesions that they see is that the lung lesions are evolving rapidly. Most importantly, there is ground glass opacities, crazy paving. The consolidations who mostly have round morphologies, a combination of all of these aspects, and especially they are in the periphery. They can be subpleural, basal, they're mostly bilateral, but they can start unilateral. And they're mostly multifocal. So the whole of the lungs are affected. And so we have a scoring system in our hospital that gives a score from 0 to 5 for each lung lobe. And so you have a total score of 25. And we say, if you are exceeding 7, the risk is very high that you have corona. If it's less, it might be that. And if it's 0, 1, or 2, it is negative. And the chances you have corona are very low. But what about those kids? Because I just said that a lot of those children who have a PCR confirmed corona don't have any signs on CT. And so there is one very good study, and there are others who also confirm a little bit the same idea, that 20 to 30% don't have any pulmonary lesions. We mostly see pulmonary lesions in adolescents and older children, but almost not in smaller children. Sometimes we can see it in smaller children too, so it's not 100%, but that's a bit the age range. A lot of them also have unilateral lesions, although most of the adults have bilateral lesions, and it's not always in the beginning of the disease compared to adults where it is starting unilateral, but almost always going bilateral. And the type of lesions are not all the same, but what is seen in adults is sometimes also seen in children. One of the extra things they see is the small nodules that were never seen in adults, but one of the important things to know is that children are often co-infected with other diseases, other viruses at the same time. And so a lot of those lung lesions could also be caused by one of the other co-infections. This is a very important slide which resumes the most important clinical features in children, that they are less often affected, as I showed you, that there is less severity, especially less mortality. There are very frequent asymptomatic or subclinical infections, because a lot of numbers in children are because they tested family clusters. And so they often discovered children secondary to adults, that there is some evidence of critical illness, but it is very, very rare, and almost no children die. And because of a lot of children are mostly asymptomatic, and also because of a lot of family clusters are tested, and often the child was not the index person, the role of children in transmission is probably not significant. Although a lot of instances or governments like ours also is demanding that children will not be in contact with their grandparents, because they might transmit the disease to their grandparents, and their grandparents are at high risk. There is more and more evidence that probably it is the other way around, that probably adults infect children. But there is no clear evidence about this. And it is true that we have to protect the most elderly and the most vulnerable population. So it is probably better that those people, the elderly and the grandparents, don't have contact with anybody at all. And so not with children, but also not with their parents. Because probably it's mostly normal adults, young adults, who transmit disease to everybody else in the adult population, and also to children. The changes that we see in laboratory and radiographic parameters are a bit different, but they are usually mild. And very important also is for pregnant ladies, there is no direct evidence of vertical transmission. I would like to say a bit more about this. There are some studies who looked at PCR in placenta, amniotic fluid in the child, in the mother, where they saw that the mother is positive. Nothing of placenta, amniotic fluid, or anything related to that is positive, and also the child is not positive. So probably there is no vertical transmission. But then they did another test where they did have some children who had a positive PCR some hours after birth. And so the question is then, was the child contaminated in the first hours when he was born, and the mother contaminated it by contact? Or is there some vertical transmission? And they also did a study looking at IgM in children, where some of the newborns had some IgM raising, but there are some questions about the specificity of this IgM, and I'll come back to that later in diagnostics. So it's not sure that the IgM rise is really about COVID-19, or is maybe a cross reaction to some other IgM. And so a lot of studies show no evidence. And also, and maybe even more important, is that a lot of mothers, and especially a lot of infants, are not severely affected. We don't have a lot of infants infected, and if they are infected, they are generally having mild disease. What we do see is that there are a lot of hospitalizations in newborns or children aged less than 12 months, which is quite logical in pediatrics in general, because that's a population that is often hospitalized way sooner than any other child at a certain age. Even if they have the same symptoms, we are way more careful, especially in newborns. And we want to monitor children in hospital. And they can more often also present with side effects like vomiting, dehydration because of less eating, and having some mild respiratory distress, but requiring monitoring in the hospital, what makes them more prone for hospitalization, but not necessarily for a very serious course of the disease, because a lot of those children are in hospital, not needing any oxygen, not needing any intensive care. And so even if there would be vertical transmission, we might be quite reassured for the child itself, not always for the mother. And another very important fact is the vulnerable children. In the beginning of the epidemic, there was a lot of anxiousness about not children only, but immunosuppressive population in general, like dialysis patients, like cystic fibrosis patients, like children with chronic lung disease, but also chronic heart disease, diabetes. And a lot of evidence suggests that those children are not at increased risk for attracting the disease, and also not at increased risk of doing a severe course of the disease. Here also, there is not a lot of data. There is mostly epidemiologic data, but in epidemiologic studies, if you compare the hit ratio, for example, in CF population, it is not higher than in general population. It's often even lower. But why is that so? Maybe because those people are even more careful to protect themselves, to stay in strict isolation, etc. And often they were also quarantined sooner than the general population, which might give not a very secure figure about how often they are affected. Maybe that protects them more, but we do see that if they contract the disease, it is reassuring that not a lot of them do a severe course, and especially very much milder than would be expected compared to their immunosuppression. And that is very good news. Diagnosis can be done in different ways. There is an antigen test, which is a rapid screening test, but has a lot of false negatives. The PCR test is the most sensitive, and I will come back to this test in detail later. You could do culture. That is a lot of work, and in our laboratory, it is not allowed because of biosafety concerns. It is not allowed to try to culture the virus for safety concerns for the laboratory personnel, but also in general, you would not want somebody starting a biological war with a coronavirus. And the problem is that this is the only test that can really prove the presence of a viable virus, which is not the case with PCR or antigen test, and I'll come back to that later. There is serology, but actually the only serologic test that is trustable, that is accurate and sensitive and specific enough, is the IgG test, not the IgM test, not the IgA test, which makes it very difficult to prove infection in an acute phase. It will be interesting to see how much people in the community are protected, but there are not a lot of studies about this. It's a test that is just recently came out. And for example, in Belgium, we could only start using it this week. And so we don't know yet how long the IgG lives in the population and if it will be a good marker of protection in the population. And then we talked about radiologic diagnosis already. About the PCR, so the best way to search for the virus is in nasopharyngeal swabs. The nasopharyngeal swab is needs to be done in a correct way. And so you should not put a little stick in the front of the nose, but it should really be put in the back of the throat, so through the nose, but almost in the throat, that you really reach the nasopharyngeal area. It can be done by swab, but it also can be done by aspiration. Then there is an amplification of the RNA, and with that, they can detect the presence of RNA in the virus, which means they could also detect that virus. So if there is viral RNA that is still in the human cell but is not replicating, then you can also detect that. And that is one of the things that is detected very often, that a lot of people are, for example, children, but also the general population, have positive PCRs on stools or even on nasopharyngeal swabs after all the symptoms are gone. And so that probably means there is still some dead virus around, but they might not be contagious because the dead virus will never be able to infect the next person. There could also be some cross-reaction with other pathogens, but here there is more data needed. And for there is always a possibility of technical problems. And that's the same for false negatives. Often the most important reason for false negatives is that there is not enough material, or maybe there is not enough circulating virus. And so the viral load is too low and it would be too early in the disease course, or maybe too late. But if you do it when a person has clear symptoms, it probably will be positive if you take the sample the right way. And some word about therapy to almost conclude is, I will not talk about intensive care therapy because, first of all, there are not a lot of children in intensive care units. And secondly, I am not an expert on the intensive care part. And so I don't have personal experience because we didn't have any child who needed more extensive treatment. And so I will not go into that in detail. But what you all should know is that the most important thing is, just as we do in a lot of other viral infections, is give supportive care. You should isolate the child from the moment you suspect it, to not contaminate your healthcare workers, because that is actually the most important part in the therapy. You isolate the child with a parent, and you allow no other visits. In every country in the world, there are no parents allowed on ICU, so PICU or NICU facilities when they have a confirmed COVID-19. And that is a problem or an issue for mothers who have a confirmed COVID-19, where their child cannot be with them in maternity, but is with them but needs to go to a NICU because it is premature or it has problems. And then the parent cannot, the mother and the father neither cannot visit their child. And they are looking at psychological effects of these consequences, and also of the quarantine in general. And so it is very important that we keep an eye on our patients for everything that is non-COVID related. and also on the psychological effects of all these measures that are put in now. We try to avoid our aerosolizing procedures as much as possible. So if not necessary, don't do physiotherapy. Don't try to do nebulization, but try to do puffs. Try to avoid throat examination and only do it if you really, really have to, and if you really suspect something, but not in a routine examination. And that should be done for every child you see, because even for asymptomatic carriers, it is important that we try to protect ourselves as far as we don't know for sure who is carrying it and who can be contagious. We use oxygen if needed and high flow nasal cannula if needed, and if necessary we can go to CPAP, we can go to intubation, we can go to intensive ventilation, invasive ventilation, but that I will not go into that too much. What you need to know is when you use high flow nasal cannulas is that it is considered an aerosolizing procedure. And so you should protect yourself more. So the room that the child is in when it's on high flow nasal cannula should be marked as more high risk. And so everybody going in, and that includes cleaning personnel, should wear the FFP2 masks and protection for the eyes. This might be overshooting, but it is the safe way. Other supportive care, especially nutrition care, fluids is important. That is like in every other infection. Antipyretics and analgesics can be used. We preferably use paracetamol or acetaminophen. And there is a myth that non-steroidal medication is not a good idea, but it is only a myth. There is no proof that it would worsen the course or it would give an adverse reaction. If a bacterial cell infection is suspected, we use antibiotics. There is, in function of what you suspect, corticosteroids are used in the ICU in adults, not as a first line, and in children, we are very hesitant because we don't know if it will have the same effects. The number of children in ICU is so small that it will also be very difficult that even at the end of this pandemic, we will not be able to draw any conclusions. There are some other medications, so like hydroxychloroquine. Kabrita is a medication that is used in anti-HIV treatment, which is now a bit more abandoned. The remdesivir is very promising and is used in adults a lot. Azithromycin is often used in combination with hydroxychloroquine. There is some anti-inflammatory medication like anti-IL-1, anti-IL-6, that is called anakinra and the tocilizumab, respectively. And they use it in adults in different combinations, and it depends on the local treatment protocols, but not in first line. In our hospital, we also use in adults a lot of Plaquenil, an anticoagulation treatment, which is also used in every ICU patient, but also patients on the ward. And hydroxychloroquine is a first line treatment. We don't use them in children who are hospitalized in the normal ward. We prefer to first do no harm and be sure that this medication is safe. There is not a lot of evidence that it is safe in this context in children. So we know that a lot of children are not going to have a severe course. So we don't use this medication only if the child will be admitted to PICU. This can be considered. So to conclude, I repeat that there is low quality evidence and everything I say can be questioned, that the knowledge is evolving rapidly, and so maybe in a week you can see articles appearing contradicting everything I said or parts that I said. Let's first do no harm, and let's and that is the main conclusion I would all want you to remember, that I talked about COVID-19 a lot, but as a pediatricians, we should really focus on all the collateral damage that could be done and on all the other diseases that are still there and that are probably more affecting our children still and more giving morbidity and mortality. And because of quarantine, because of limited healthcare access, because of anxiousness in the parents of not wanting to go to the hospital, we are already seeing late presentations and probably damage because of other diseases than corona. And I think that should be our focus as pediatricians. And so it's good that we know what to do with corona patients, but we should still focus on everything else. These are some of the references I could not write in full in my slides, and I would like to thank you for your attention. I think there is room for questions now.
Yes, okay. Yes.
Should I stop?
Yes, okay.
I will stop.
Thanks, Dr. Seal, for this excellent presentation. Yes. You hear me?
Yes, I hear you.
Yes, okay. Thank you for this excellent presentation.
Thank
Sorry?
you. Okay. Are there some questions?
Sorry, we have 63, not 36. 63 questions.
Okay.
Yes, okay. First, I'd like to announce, because there is a lot of question about the CME accreditation before, I'd like to announce that CME accreditation is a 3 hours, which is excellent, accredited from American Association for Continuous Medical Education. Yes, Dr. Mohammed from Hyproca Nutrition, Kabrita, will discuss them when we talk by email or directly to the doctor. Yes, okay. Let us to start, doctor. First
Yes.
question: does COVID-19 come to an end with a hot weather?
No.
No.
Yes and no. I will show you my slide again. I didn't.
We can talk. I just enumerate the question also.
So I will just look. I will not show my slide. I will just talk about it. Is that
Yes.
it is that the virus is inactivated by heating at 56 degrees for 30 minutes, or higher temperatures for a bit shorter, and especially longer, it will be fine. So normal sterilization is enough to kill the virus, but the water should be hot enough, and hot water is what we use for a hot shower is not more than 56 degrees, but then because then you get burned. So washing your hands only with hot water is not helping, but soap is very effective. And so cleaning devices, you can clean with very hot water, but the problem is that you will probably not be able to touch the water because you will burn yourself. So yes, it is killed in high temperatures, but no, it is not a very effective way to use hot water because you will probably burn your skin before you kill your virus. So it's better to use ethanol or soap to kill the virus.
Yes, also hot weather.
Oh, hot weather. I'm sorry, I thought hot water. Hot weather? No. There is no evidence. In the beginning, there were some thoughts that maybe it is in more tropical areas, it comes less frequent. Well, there is less confirmed cases. It might come just later. It might be that there is not enough testing, for example, in Africa. Probably a lot of people are sick and there are less access for testing. And the numbers are not that easy to be monitored as in the Western developed world. But it is a hypothesis and it is not confirmed yet. So I cannot really say yes or no, but probably not.
All we have next July, August, September.
Yes, we don't know. We know that a lot of other viruses are mainly coming in epidemics during wintertime or during colder periods. But and this was also the case with the coronavirus. So we hope that it might have an effect, but we don't know which temperatures should be reached and how long. So we don't know. Maybe if there is a very good period of tropical weather, it might be gone, but we are not sure because it might come in the world in tropical areas just later. And then those areas are also already now, you can see, for example, in India, that there are areas where they have way better weather than they do have in North America or in Belgium, for example. And so still they are having a lot of disease. So let's hope, but
yes, let's hope. Regarding the use of hydroxychloroquine in children and has spasm, safe or there is alternatives? They ask about the relation with spasm and hydroxychloroquine.
The azithromycin and no, I didn't understand.
Hydroxychloroquine in children and has spasm. It is safe or there is alternative?
And health? What? I'm sorry, I didn't understand.
Yeah. Hydroxychloroquine and the children with spasm. It is safe or there is alternative? They ask about the safety of hydroxychloroquine in children has spasm and the COVID-19. Any evidence about this?
In children who have COVID-19 and what else?
Spasm, G6pd deficiency.
Oh yes, sorry, I didn't capture.
Yeah, G6pd deficiency. Yeah.
Well, actually, it's a contraindication to use it.
Yeah.
And as known in general of G6pd deficiency is that it could harm, but not every medication and not in every dose will harm every child. So it is a risk that can be taken, but preferably not. And especially not because we don't know for sure that hydroxychloroquine is really helping in children affected with COVID-19. And also, a lot of those children are not that ill, and they will have a mild course of the disease. So then it's very important to not take any risk and just let them cure by themselves. And first, do not harm.
Yes.
But in severely ill children, when you are more with your back against the wall, you should consider every option and you should weigh risks and benefits. And if you don't know the G6pd status of your child, you might try it, see what happens, and hope for the best.
Yes.
That's the same in every other intensive care unit where you have to use medication and have to decide quickly and cannot wait for a test, for example. Then sometimes you take the risk.
COVID-19 is less severe in children with low mortality rate in children. Yeah.
Yes.
Another. Why use of anticoagulant in COVID-19?
Well, that is it's from the adults. We probably think that it doesn't have any use in children. It is because they saw a lot of deep venous thrombosis and a lot of lung embolisms in adults when they were severely ill, so in intensive care units. And they don't know exactly what the physiologic pathway is behind this, but they think it might have something to do with the ACE2 receptor. And so they saw in Italy that once they started giving anticoagulation as a standard therapy in every person admitted to ICU, they saw mortality rates drop. They did also do other interventions at the same time, like using methylprednisolone, so corticosteroids in those requiring, in those with respiratory failure of a certain degree. And they use hydroxychloroquine in everybody, and they don't know if it's attributed to which one of the interventions they did, but they do think that the anticoagulation has effects, and there is some evidence that it reduces morbidity and mortality. But that is all in adults who are prone to do thrombosis We don't know if it will help in children, and we don't want our children to bleed neither. So we don't give it as a first line treatment in children. And it's in not a lot of PQ protocols. It is.
We have 191 question, yeah?
Oh, it's rising.
191, you see that?
Ah, yes, I see.
Yes, 121. Yeah.
Okay.
Another question, what is the proper management for baby delivered to positive coronavirus?
The management in the delivery room, what we do is, and what most countries do, is we give protective equipment to everybody involved. So the gynecologist, the midwife. We try to keep our pediatrician as far away as possible, but also give them protective gear. And we try, if there is a pediatrician asked in all of those deliveries, because one of the guidelines for gynecologists is that they have to deliver quicker. So they cannot accept prolonged labor. And there is thus more risk of using at-risk procedure for the child, because they will try to get the child out as soon as possible. It is because they are not sure there is vertical transmission. They don't want the mother to be exhausted too quickly, because you do think she might have some respiratory disease and might be exhausted respiratory.
Okay.
And also you don't want to let her cough too much. And so we try to separate the child only for the examination. But if the mother is fine and the baby is fine and they are capable of carrying, then the child stays with the mother in isolation.
Okay. Another question. Why BCG vaccinated children are immunized against COVID-19?
I don't...
From his opinion, yeah. Yes.
I have to say I don't know. I have not seen a link. I am not aware that they are protected. We don't vaccinate in Belgium with BCG vaccination, so we don't have any children vaccinated. And I am not aware of any literature about a link, so I cannot respond to that question. I'm sorry.
Yes, okay. What is the explanation for prevalence in male more than in female for all age?
Well, we don't know. It is in younger persons, also in older persons, and there are some hypotheses, but actually there is no proof of why it is that way. We have no idea. And if we find the answer to that question, we might find directly a solution to maybe a new therapy or whatever. Maybe we can give everybody estrogens and hope that it helps, but we don't know.
Yes. Do you expect another waves, other coronavirus in future?
Yes, I think in general, we already see a trend with SARS, MERS, and then the COVID-19. It will not be the last coronavirus circulating, just as we will not eradicate the flu anytime soon. If it will be the next pandemic, I don't know, but there will be more pandemics. I think that is part of our globalization, part of how we live these days, and how many people live in this world and how close we live all together. So it's and all those viruses are mutating and getting stronger and stronger. So I think it's this pandemic will learn us a lot, and hopefully there will be other pandemics, but hopefully we can respond to them better than this one.
Yes. Okay. It seems that children present with GI symptoms more than adults.
Yes.
Why?
Yes. We
Why?
don't know.
I
We
don't know.
why. We don't understand why. We also don't know if it's really only corona itself, because we see a lot of co-infections in children. And so even if you find another virus, you should be aware that there could be coronavirus in the child. And so this might be one of the reasons why those children are maybe co-infected. Maybe they have a quite asymptomatic coronavirus in their nose, and they have an adenovirus in their gut at the same time. But when you count these children as a coronavirus, which they have because they have it in their nose, then, and you write down all the features, then you know then one of those features is that they had diarrhea and they were vomiting. But maybe there were other viruses that you didn't test for, or you don't know why they have.
Okay.
So it's very difficult. But yeah, I think
till now, yeah. Till now. What about the use of gloves during the examination? WHO suspect that gives a false safety feeling. What's
yes,
your opinion?
I think it can protect, but it doesn't protect better than using soap or alcohol, hand alcohol. So sanitizing your hands is probably more important. Even if you take off your gloves, you should sanitize your hands anyway after. And the danger is that people put on gloves and then touch contaminated things, and then touch their face, which is not the way it should be, because then you contaminate yourself anyway. If you don't wear gloves, you are probably being more aware of what you do with your hands, and you will probably feel if you are touching somebody's sputa, for example. But it's yeah, it's difficult. I think
some patient, yes,
you use it correctly.
Okay, some patient may be asymptomatic, but they have extensive pneumonia on X-ray or CT scan. So do you think it is wise to treat them or only observe?
I think it's wise to just observe. You should always go for clinics first. And even if we see radiologic, even extensive radiologic signs, we know that a lot of those people, adults or children, can have a mild course of disease, even if their CT scan is quite spectacular. Doesn't mean they are going to be very sick. So you should first follow up on your patient clinically and only act when necessary.
Yes. Is there a relation between infection and alcoholic drink consumption?
Not that I'm aware of.
Yes. How much COVID-19 differs from seasonal influenza as regard to morbidity and mortality?
It is, well, a lot of the seasonal influenza, we have a flu vaccine, so we protect our most vulnerable patients. We protect, we make sure there is less influenza in the community because we protect some people. And also the flu is not a novel virus. It is a mutated virus that is circulating in the community since a very long time. So there is always some more herd immunity. So this virus seems more contagious to start with, probably because there is no herd immunity, and probably almost nobody ever contracted a coronavirus before, or a coronavirus that looked similar enough. And so probably everybody who contracts it will, well, there will be a bigger proportion that gets sick. But and then the severity is probably worse or different. It's different, especially that immunosuppressive patients are not the most vulnerable in this. It is in the flu in the general flu, but not for coronavirus. And a lot of healthy individuals, they are affected, and some of them with no comorbidities are doing some severe disease, and we don't understand exactly why. It has to do with the inflammatory response and the cytokine storm, and that probably makes this, because of contagiousness and because of more people affected and more healthy people affected, more severe disease. Yes, I think so.
Yes. Why lymphocytosis in children against lymphopenia in adults in COVID-19?
Yeah, we don't know. We see lymphopenia sometimes in children too, but a lot of them have lymphocytosis, and we don't understand exactly why. We do think that in general, the reason why children are less affected or less sick when they get COVID-19 is probably because they do a different inflammatory response. And the younger you are, the less inflammatory response we see, or the less sick the children are. So probably there is your immune system is immature or immunosuppressed, and that protects you against corona. So it's that might be the reason why we see more different laboratory reactions, but we don't exactly know the pathophysiology.
Yes, okay. How to catch a newborn with COVID-19?
How to diagnose it?
Catch, yeah. Okay, diagnosed, yeah.
PCR, we do PCR on nasal
Without
swabs.
symptomatic, yeah?
Yes, often
Yeah,
they
I
are.
think.
We test all of them. You can test at birth or at 24 hours, and then we test again at 72 hours. That is the recommendation of the AAP. In the UK, they test at 3 days and at 5 days, but just to be sure, so they prolong it a little bit. The question is, of course, if you have a later PCR that is positive, is it because of vertical transmission? Probably not. It's probably contracted after birth. Except when mother and child or parents and children were separated. But that only happens in our case in the NICU.
What about vaccine?
Yes, there is a vaccine coming, and we hope it will be soon. So we hope in the year or the end of this year. And that will probably help us protect for the next coronavirus pandemic. Let's hope for all of them, but it's not sure that the virus will not mutate enough that it might not protect enough.
Yes, use of mice and the fact shouldn't be used for COVID-19 because of everything is observational. Do you agree?
Yes. Yes.
What is the protocol for this of discharge from isolation?
Yes. Home isolation is installed at least for 7 days, and the person who has symptoms should be at least a week at home and should be 3 days without symptoms and with a definite improvement in respiratory symptoms before they can go come out of their isolation. So sometimes it takes more. It takes more time than those 7 days. Sometimes it's 7+, because if you're at 7 days not asymptomatic, you should still be in isolation. And for healthcare workers, they can come back to work when they have those criteria fulfilled, but they keep wearing a mask until 14 days after the first symptoms.
Yes.
Even if they are weak asymptomatic, they keep on having their protection.
Yes. Use of zinc and vitamin D as adjuvant therapy. Zinc
yes.
and vitamin D.
For it is often, there are, it's especially in the American protocol, I think zinc is used. Vitamin D, I'm not really sure. The evidence is low also. It is often used as an adjunctive, and it's mostly because it doesn't harm too. So it's not a bad thing to give it, but it's probably not the main thing. I don't think it will help preventively. There is no proof that if people are in the general population will start taking zinc and vitamin D, that they will not get infected. And it doesn't replace the first-line treatment like hydroxychloroquine in adults. So.
Yes, okay. As you see, we have 205 question, which it is too large. And I think it is the time to invite Professor Van den Blas to be with us in a communication. Professor Van den Blas?
Yes, hello.
Hi.
I'm back.
Yes, hi. Thank you, Dr. Seal, yeah? We will ask some question. Thank you, Professor Van den Blas. I am happy to cooperate with you in this, with you for this webinar.
Pleasure.
My question to you, what is the novel treatment of functional gastrointestinal disorder? This is a question here.
Novel treatment?
Novel, yeah.
Well, I think that what we try to convince our colleagues is that for functional disorders, it's nutritional treatment very often brings improvement together with the reassurance. Because I think that anticipatory guidance, reassurance is very important. But if you only explain to the mother without doing anything else and without prescribing something, she will not feel taken seriously. So I think it's important also actually to change something and to do something. And there is quite some literature that nutritional treatment is effective and is absolutely safe. And that's why we should stay away from medication as much as possible.
Yes, okay. Another question, what are the relationship between irritable bowel syndrome and functional constipation?
Well, the question is the opposite. Is there a
Yes.
difference very often? Because
Yes.
chronic constipation causes chronic abdominal pain in a lot of
Yes.
patients, and that's what IBS is. And a lot of chronic abdominal pain children are treated very effectively if you treat constipation. So I think that for children with chronic abdominal pain, older children, then not the age we are talking about for infants, but children of 3, 4, 7 years old with chronic abdominal pain, management of constipation is very often a solution, even if there is no classic complaint of constipation, even if they go daily to the toilet, and still constipation and laxative treatment can be very effective.
Yes. Other proton pump inhibitor rather than omeprazole can be used in treatment of GERD in infant?
Well, yeah, it's omeprazole or esomeprazole or pantoprazole, which are the most currently used, but they are all from the same family. So it makes, I think, no sense to switch from one to another. If one would not help, the other will also not help. So I think what we must learn also is that if a proton pump inhibitor does not help, we must accept that the wrong diagnosis. Acid reflux is not causing these problems, and we should look for another diagnosis.
Okay, is there a relation between food habit and functional gastrointestinal disorders?
Between
Food habits. Food habits.
Well, yeah, well, again, I think if you exaggerate and have too much of some specific foods, for instance, drinks with bubbles, gas drinks, that can cause a lot of, bring a lot of air into the bowel and cause cramps and pain. So you should look for a dietary history and see if the diet is well balanced. But in general, with a balanced diet, if there are no exaggerations, then overall it's not causing problems.
Okay, in cow milk protein allergy prophylaxis, can we use goat milk?
Yeah, well, the child will not get cow's milk allergy if you give him goat's milk. He will get goat's milk allergy. But so I don't think it's a real prophylaxis for allergic disease, because I think that the incidence for allergy to cow's milk or to goat's milk is the same.
Yes. Do you think that overusage of antispasmodic will lead to constipation?
That's certainly one of the causes of constipation, and I think that antispasmodics overall are not indicated in the management of chronic abdominal pain. There is no evidence that that is really helpful. We should look for a cause which is causing the pain. And then again, constipation is the #1 by far. So I see much more benefit in giving polyethylene glycol than antispasmodics in children who complain of chronic abdominal pain.
Yes, is there any relations between functional gastrointestinal disorder and the cyclic vomiting syndrome in neonate?
Ooh, questions gets more and more difficult.
This question is from one of our dear professor of neonatology.
Yeah, well, cyclic vomiting syndrome has also, it's an unclear disease with which can be considered as part of also neurological disorders, where in fact the treatment that you use for some neurological disorders is effective for cyclic vomiting syndrome. I think probably you will find a relation, because functional gastrointestinal disorders are so frequent that children with cyclic vomiting syndrome, if you have it, as I said in my first slide, if you have an organic disease, it does not protect to develop a functional disorder. And a functional disorder, it's 20-25% of all the children. So yes, 1 in 4 with cyclic vomiting syndrome will have a functional disorder, but that's probably just by coincidence.
Okay. Dr. Seal, how long does the viruses stay in meat, fish, vegetable?
I don't know.
They are in the refrigerator, yeah.
I don't know. I cannot answer that question. I know that.
But if you cook the meat,
Yes,
it gets
cook
above
the
the
meat,
50 degrees. It's killed.
Well, then it will. If you don't eat it raw, then there will not be a problem. And I don't know about refrigerator temperatures and how much that affects the virus. But if you don't eat it raw, it will be fine.
Yes. Okay.
And deep freezer, -20.
Probably it will help, but I don't know what the minimum degrees is when the virus dies in negative way. So I only know 56 degrees is the minimum, and it should be 30 minutes, and everything above that, like 100 degrees, can be shorter. So if you cook your food properly, there is probably no problem. And then there is also the idea that how long does it, we know that it is viable, the disease on surfaces, but it's mostly viable on like stainless steel, for example. It can be viable for up to 72 hours, but probably on other surfaces, it is viable only for a few hours. So the time you buy it, you put it in a refrigerator and then start cooking it, the virus is probably already dead because it takes a few hours.
Yes, okay. We have a lot of questions, but this is the last one to Dr. Seeley. Pertussis measles vaccine, is it play any rules in immunity against COVID-19?
Not that I know of directly. I do know that the measles, in general, if you contract the measles, that it gives you an immunodeficiency afterwards, and you are more prone for infections. And so in a way, the measles vaccine protects you from that post-vaccine immunosuppression. And so in that way, I would say you should better continue vaccination as much as possible. And also, we know there can be co-infections, and you probably will be sicker of your measles or your pertussis than from your coronavirus as a small child. So you definitely want to avoid those. But a direct relation, I don't know.
Yes, finally, I thank Professor Van den Blas and Dr. Seal for this excellent webinar communication with you. And thanks also to Hyproca Nutrition for supporting and sponsoring this webinar. I just introduced Dr. Mohammed Hussein with us. Dr. Mohammed? Yes?
Yes, thank you. Thank you,
Yes.
Professor Weil.
Yeah.
Well, Professor Weil, thank you very much for the whole organization, working also with you in the Egyptian Pediatric Academy for organizing this webinar. I think it was very well organized, honestly. This is my first time to attend maybe a big webinar like this. But more and above, I would like really to extend my immense appreciation for Professor Van Blas and Professor Seal for the informative lectures that they have delivered today. I really learned a lot from that. And I think that it was quite useful learning, okay, to get these updates from Europe, okay, and I believe that all of us are learning a lot, okay, day by day when it comes to this interesting area of in the pediatrics and infants. So I'm really grateful, really, it was quite good. I see a lot of interaction, I see a lot of questions. I know there is plenty of questions. Of course, we cannot answer all these questions, but we will try. We will send it. We will send these questions.
I will send it to Professor Van den Black to respond to this by email. Yes,
I know that they can do it and they can answer it for us.
All attendance.
But it is, it's difficult and challenging to get the answers to all the people here. But
we are at 209 questions.
Yes, God helps. Before I make my final closing, I just have to comment on one of the questions which was repeated a lot about the use of goat milk in allergic cow milk disorders. For our audience, I need to stress this is not a hypoallergenic formula. Okay, this is a regular formula, just like any other milk substitute, but of course with the advantages of being brought from goat milk. It has its own advantages, it has its own disadvantages as well. Okay, so at the end of the day, I'm sure that the choice will be for our white coat doctors. I'm sure that they know very well what they will take for the benefits of the babies and for the infants. I'm sure also that the area of development in science in this area is a lot. There's a lot of work. Okay, every day we see something new, which is good. I mean, getting into research and getting into more details will be very useful at the end for the community. More interestingly, to learn about COVID and what's going on, I hope that we're able, through our white coat, our research, to defeat this disease, okay, soon. And hope that all of you are protected, all your communities are protected. But now it's God hope, it's God who is going to protect everyone. Yes. I'm sure with our frontline white coat people who are really taking care of this difficult time dealing with our babies even and adult people. I hope that everyone gets safe. And again, thank you very much on behalf of Osnitria and Hyproca Nutrition Middle East. I'm sure we're going to continue our pathway more and more in that area of interest for everyone. Again, thank you very much. I hope all the best for all of you. Thank you.
Thank you, Dr. Muhammad. From now, we spend about 2 hours 37 minutes. It is much. Thank you, my dear Professor Van den Blas and Dr. Seal for this excellent communication. Thank you for all my colleagues
with pleasure.
Attendees. And thank you for Hyproca Nutrition and Kabrita.
Finally,
excellent.
Again, before you leave, Dr. Salah, I would like to thank all the people who attended. Sorry, I didn't miss that, but I'm very thankful for them. Very thankful for their interaction. Very thankful for their interest. I hope we can do more. We have interact more and give all the support to the medical community. Thank you very much again.
Yes.
Thank you.
Thank you. Thank you very much. That will end. Bye. Thank you.
Bye.
Bye.
Babies are born to be at ease. Nothing lets babies grow more at ease than their mother's love. But moms find it hard to follow their intuition when facing so many good intentions and advice. We believe that nature has given moms the confidence to follow their own path. That's why we support breastfeeding, the best nature has to offer. And that's why we commit ourselves to creating the gentlest nutrition for the most precious little creatures in our lives. Kabrita is made with the natural gentleness of goat milk. It comes with the love of our farmers for their goats, the centuries-old tradition of the Dutch for dairy, and the dedication of our experts for crafting the very best nutrition every day. Because we truly believe this gentle touch of nature makes all babies grow with ease and lets their moms sleep a little better too. Kabrita, gentle by nature.